All right, if you're gearing up for the EDREE, you know oral surgery is a big deal. But here's the secret. The thing most people miss. The exam isn't trying to see if you're a world-class surgeon. Nope, it's all about your clinical reasoning. Can you manage infections, spot an emergency, and avoid those classic post-op traps? If you can nail those things, you're going to do great.
So, here's our game plan for today. We're going to start with the common traps the exam loves to set. Then, we'll dive deep into infection management. This is huge. After that, we'll cover post-op complications, test our knowledge with a few clinical cases, and wrap it all up with a solid action plan for you.
Okay, first things first. Let's get into the right mindset for this exam. It's not about knowing everything. It's about understanding what they're actually testing. And that's your ability to be a safe, smart, and competent clinician.
So seriously, forget trying to memorize complex flap designs or surgical steps. The EDREE is testing your clinical brain. It's basically asking you, hey, can you tell a serious infection from a minor one? Do you know when to pick up the phone and refer? And can you figure out the right order of treatment? It's all about critical thinking. Now, let's get into our first major clinical topic, odontogenic infections. This is a massive part of the exam, and getting this right is, well, it's absolutely fundamental. This is your first critical decision point. So this slide breaks down that first big decision you have to make. Is it cellulitis or is it an abscess? Think of cellulitis as a diffuse, firm, kind of doughy swelling. For that, the answer is antibiotics and, of course, removing the source. But an abscess, that's a whole different animal. It's localized, it's walled off, and it's fluctuant, that boggy feeling. For an abscess, the #1 priority is incision and drainage. And this right here, this is a golden rule, and probably the biggest trap on the entire oral surgery section. You have to remember, antibiotics alone will not cure an abscess. They just can't get inside that walled-off pocket of pus to do their job. So if you see pus, if you see an abscess, your first move is always to drain it. Choosing only antibiotics is the wrong answer they want you to pick. Don't fall for it. Now, sometimes an infection gets really serious, really fast. You absolutely have to know these airway red flags by heart. We're talking difficulty swallowing, drooling, a rising floor of the mouth. These are not just simple dental problems anymore. These are signs of a deep space infection that could shut down someone's airway.
So, here's the deal. When you see any of those red flags in a question stem, your job is not to play the hero. The next best step the EDRE is looking for, 100% of the time, is an immediate emergency referral. Recognizing that severity and acting on it is the skill they're testing.
Okay, let's switch gears. The extraction is done, but your job isn't over. Let's talk about managing post-op complications, because your clinical judgment is still very much being tested here.
First up, the infamous dry socket. The key things to look for are all right here. The pain is severe, but here's the kicker. It doesn't start right away. It hits a few days after the extraction. When you look, you'll see an empty socket, maybe with some exposed bone, and patients often report a nasty smell or taste. That's the classic picture. All right, pop quiz, and this is a huge one for the exam. A patient walks in with that textbook dry socket we just described. They're in agony. What's your move? Are you reaching for that prescription pad to write for antibiotics? The answer is a clear, definitive no. This is so important. Dry socket is an inflammatory issue, not a bacterial infection. Systemic antibiotics do nothing here. The correct management is all local. You gently irrigate the socket, you place a soothing medicated dressing in there, and you help the patient manage their pain. That's it. What about bleeding? The exam wants to see a logical, step-by-step approach. You always start with the simplest thing first. Get some gauze on there and apply direct pressure. If that's not cutting it, maybe you need a suture. Still bleeding? Okay, now you can think about hemostatic agents. And if nothing is working, you have to start wondering if there's a systemic issue going on. And what happens when a root tip breaks off? Your first instinct might be to chase after it, but that's not always the right call. The EDRA tests your judgment on this. If that fragment is tiny, deep in the bone, there's no infection, and digging it out could damage something important like a nerve, the safest and best decision is to leave it be and, of course, document and inform the patient. All right, we've covered the principles. Now for the fun part. Let's actually apply this stuff. We're going to run through a couple of quick EDREE-style cases. I'll give you the scenario, and you figure out the single best next step. Okay, here's case number 1. A patient comes in with diffuse swelling under their jaw. They can barely open, they have a fever, and they're having trouble swallowing.
So, what do you do right now? What is your immediate next move?
The only correct answer is an immediate emergency referral. This is not a situation for your dental office. That combination of fever and difficulty swallowing is screaming deep space infection and airway risk. This is the classic recognize and refer scenario in action.
All right, case number 2. It's 3 days after an extraction. The patient calls, they're in severe pain, and when they come in, you can see exposed bone in the socket. This should be ringing some bells. So what's the correct management here? What's your very next action?
If you said irrigate the socket and place a medicated dressing, you are 100% correct. This is textbook dry socket. And notice, you successfully avoided the trap which would have been to prescribe antibiotics. Nicely done.
Okay, let's bring this all home. We're going to wrap everything up into a simple, clear action plan you can take with you as you keep studying.
Here is your checklist for oral surgery on the EDREE. First, master the difference between cellulitis and an abscess. Second, know that golden rule. If there's pus, you drain it. Third, be rock solid on managing common post-op complications. And finally, train your brain to constantly ask, what is the next best step? That thinking process is the key to passing this section. So if you want to really make sure these concepts stick, the best way is to practice with exam-style questions. We've actually put together a free PDF with sample multiple-choice questions that cover exactly these kinds of topics. The link is right there in the description. Go download it, test yourself, and see where you stand. Good luck with your studies.